Thanks, Brendan. So just follow on a bit from what he said, because the report only includes 106 papers, but there is actually a fair bit more data about other buildings that's not included in the report that needs to be included perhaps in the next version. For example, data from education departments that we know at least New South Wales Education Department and Queensland Education Department have been collecting indoor air quality readings for a while, but that data has not been public. I know that Southern Cross Station here in Melbourne had some indoor air quality studies done, but that data is not public. There's also a fair bit of data from those of you who are consultancy companies who have measured indoor air or mould or other things in a heap of buildings. So perhaps future iterations of this report can include some analysis of that other data as well to give a clearer picture of where we are. So joining us on the panel, joining Anna-Marie and Brendan on the panel, we also have Professor Giorgio Buonanno, sorry if I said that wrong, from the University of Casino in Southern Lazio in Italy, and Professor Guy Marks from the Burnet Institute. So I'm going to start by asking a few questions while you think about what questions you want to ask, and there are some roving microphones, I understand. So Brendan said before about the evidence base, and in the National Construction Code, in the Air Quality Verification Handbook, the Building Codes Board specifically says that they don't include any bioaerosols or mould in the requirements yet, because the scientific evidence is not clear. What do either of you or anybody on the panel want to say about does the scientific community have the evidence to support the importance of mould and pathogens, and what might the limits be that could be included in the building codes?
You want me to?
Yeah.
Okay. First of all, I want to point out that I can see that only Brendan and I got the memo about the socks today.
That's right.
Oh, yes.
So
everyone else has let.
But yeah, on it's an interesting question. I've been involved in this for quite a long time, and early in the period where we talked about indoor air quality, in fact, one of the major drivers was Legionnaires' disease. That is a bioaerosol. It's not a human-to-human infection. It's from waterborne sources, and it was, as people probably know, first identified in Philadelphia at a Legionnaires' conference around about 30 years ago. I can't exactly remember when. My late colleague, Ewan Tovey, did a great deal of work on bioaerosols associated with moulds, fungi, and there are others, I think, in the audience. I see Amanda there, who's done quite a lot of work on this topic as well. It's true that the health effects of those exposures are not clear, particularly the dose-response relationships. So there's no doubt that very high dose exposures to fungal spores will cause problems, but the dose-response relationship and the way in which it becomes airborne in an indoor environment are not clearly established. Also, the nature of the health effects is complex. There are some, particularly for Aspergillus, which is one of the sort of moisture-associated moulds. There are a lot of different ways in which Aspergillus exposure interacts with the body. Some of them are allergic type mechanisms. Some of them are more infectious type mechanisms. Invasive Aspergillus disease, for example, in people who are immunosuppressed. So all I can say about that is that it's a very complex area, not an area, and many of these things that we're talking about here are actually quite complex. So I'm not I don't strongly disagree with the view that this is not yet all worked out.
And that perhaps raises a question of how much scientific evidence do we need before we start managing and or regulating? Do we need all the scientific questions answered first, or do we take from a medical the precautionary approach?
Well, yeah, people talk about the precautionary principle a lot, but often the actions that you take have their own consequences, and sometimes they're not the expected consequences. So being precautionary in one direction might actually have adverse effects in another direction. So I'm not sure that I frankly don't find the precautionary principle a very good principle to guide me, because it's not every action you take has a consequence. And whether it's for energy efficiency or for comfort or for cost or for whatever, there is no one outcome. There are multiple outcomes that need to be balanced against each other. You know, there are lots of examples of that sort of problem.
I think just considering bioaerosols, though separate necessarily to the complexities around mould and fungi, the step change has occurred. The appreciation that respiratory infections are transmitted by aerosols, not primarily by the droplet spread dogma, is the profound shift that should drive the change. The chief scientist of the World Health Organization, when she left the Earth in late 2021, said it was her biggest regret not acting on the aerosol nature of respiratory virus transmission. So there is clearly enough evidence for COVID and flu, for example, not to mention adenoviruses and rhinoviruses and parainfluenza viruses and the others that transmit in that way, that we're now talking about aerosol transmission. There's enough to act. The question is exactly how to make the most difference in whatever setting, but it's an absolute paradigm shift that's occurred in public health understanding of the scale of John Snow and cholera and typhoid.
Yeah, I agree.
Giorgio, you wanted to say?
Yes, can I say something? In my opinion, the discussion now is not if there is an evidence of airborne transmission of pathogens. In April 2024, few scientists of the group of 36, Lydia and me were among this very, very little group. We participate the publication of a document of the WHO, and in this document, the main way of transmission of all respiratory pathogens is through the airborne transmission. So at the moment, I think we don't need the evidence because we are sure that there is a problem with airborne transmission. Can I share?
Yeah, so I'll ask that in a moment. So we've been talking a bit, and Guy mentioned about actions can have perhaps unknown consequences as well. So in some of the papers we've been reviewing have looked at what are the implications of some interventions that have been made. UV disinfection was one of those, some more advanced ventilation systems for some of those. But the adverse or the unexpected consequences of some of these was a rise in ozone or a rise in ultrafine particles.
Yeah.
So I want to. So I've asked Giorgio to speak specifically about how can we make sure that some of our interventions to reduce these pollutants don't cause unintended consequences of rises in other pollutants. And is there for me, as a non-aerosol scientist, is there a hierarchy of pollutants that we should be addressing before other pollutants, etc.? And Giorgio has been conducting an experiment, or wants to talk about that.
Can I?
Yeah. So it's all.
Yeah, I understand. So first of all, in order to explain how is complex the indoor environment, let me give some information about the classrooms, how we can manage the classrooms. Giving you an example of Italian classrooms. We have a law that was introduced in 1965 in Italy that introduced the number of air exchange rates in the classroom is mandatory. But this law was not considered till now, also now. Why? Because CO2 was considered a parameter, pollutant, that affects only cognitive or comfort. It's not important. It is considered more important to protect students from pollution coming from outdoor. So natural ventilation, that is the base in Italian schools, was considered not a well-done measure to protect people because there was the introduction. So you have to consider that when you introduce the concept of airborne transmission, you can change the way to manage the environment. So let's see now this environment. We will stay here 3 hours. Do you consider this as safe conditions in terms of airborne transmission? No. Why not? Not or yes, you have to measure. So this is what we did. So we start from the measurement of CO2, and CO2 is a very easy way to measure CO2. So the value that we had after 1 hour was, stationary condition was around 1000 ppm. Using this value and on the basis of the number of people, we can estimate the ventilation rate here, and it was something like 2.5 air exchange rate per hour. Okay, this is quite good. But the question is this a ventilation rate? You know that ventilation is probably the best way to protect from airborne transmission. It's good, 2.5. Okay, we have developed during the pandemic a model in order to measure the airborne transmission and the risk, the probability of the risk. And you can see that having considered in this scenario one infected subject, and this subject is only breathing for 3 hours, so one of you that is sitting there is not speaking, because if you start to speak, increase the emission of airborne or respiratory particles. In this case, you can see that at the end of the 3 hours, there is, in 3 hours, the probability of 2.1% for each of us to be infected. It means that we have, in order to guarantee reproduction number less than 1, the maximum occupancy here should be 48 people. The number here was 81. Okay? So the question is, does these air cleaners help in order to reduce? Yes. The increase of equivalent ventilation was something like 2 air exchange per hour. And now the value was 72. 72 is close to 80. So quite good, not enough. We need, in order to have a reproduction number less than 1, other 2 air cleaners. Remember for the next conference. So, and we can estimate also the probability of different events. So what is the probability to have from less than one infected subject from here? You can see 71.5%. But can we have here an outbreak in this scenario? Yes, more than 7 people is 3.5%. So this is something that we can, of course, estimate. But if we change the scenario, because there isn't only the scenario with COVID-19 and one person breathing. We can have one person speaking a different pathogen. And you can see here different pathogen, measles, no air cleaners. And the scenario is one infected subject speaking for 20 minutes at the beginning, after 10 minutes from the beginning of this session, of the previous session, and then the same person continues breathing. Who was this person? In the hypothesis, Lydia. Sorry for this. So, what is in this case the maximum occupancy? You can see 37, less. And if we use the air cleaners, 57. So in this case, different scenario, we need more equivalent ventilation, so four more air cleaners. So, but this is something that, okay, people knows that when there is an occupancy, we have to manage the indoor environment. But what about bedroom? Bedroom is a simple environment. We think that there are no pollutants in a bedroom. I monitored, we performed in the past several papers trying to understand the correlation, the influence of indoor air quality on sleep quality. And one of the parameters that is very important is, of course, CO2. Because if there is an increase of CO2, there is a decrease of the sleep quality. And this is important because if you stay in this condition day after day, then you have some impact. And consider that a decrease of 100 ppm of CO2 is associated with a decline of 0.3% of sleeping quality. So what I did is to monitor this night in my bedroom CO2. And it's a very, very good trend. Because the concentration, this is a good spot for the hotel. The concentration of the CO2 was lower than 700 ppm. Consider that if you don't manage the air quality, the concentration during the night in the bedroom could reach 4,000 ppm, in particular if you are not alone. My advice is to sleep always alone, for sure. And starting from this, I have estimated the ventilation in my bedroom the same way. It was 3 air exchange rate per hour. Very good. And you can say, okay, is good or not for health? But now we measure also the sleeping quality every day. Every day. And what was the result? You can see it's in Italian. I copied this morning. Was an excellent night. So very good quality, very good sleeping. This is only to say that the management of each environment is different from the other environment. It depends on the environments, but in principle, we can manage this. Thank you.
Very interesting.
That was really interesting, and it's good to see the models that have come out to look at what the reproduction rates are and the ventilation rates. In the building space, for this room, for example, this room, the construction codes have a occupancy rate of so many people per square metre, and the size of the doorways is determined by how quickly we can get this room evacuated should there be a fire. So in the building codes already, the potential for a worst case scenario is built into the building codes to determine what is the maximum seating capacity of this space, and therefore how wide should every doorway be and the corridors until you get to an outside safe space. So that leads to potential for the likes of the types of modelling that's been done regarding what should the ventilation or air change rate be in buildings at particular points in time is just a similar sort of process. We already have these types of processes in our building code. I want to perhaps take some questions from the audience. So there's a couple of roving microphones. So put your hand up high if you have a question, and the microphone will come to you. And if it's to a specific person or to the panel as a whole.
Hi. Is it on? Hello?
Yep.
I'm David Chen from the Northern Territory Government. I've got a couple of questions to ask. And first of all, with regards to Legionella and how it got incorporated into the Australian standard.
Put it a bit closer to you.
Oh, yeah. With regards to Legionella and how was it incorporated into Australian standards? And was that based on data, or was it based on a reactive of what happened in America that we need to be protective of in Australia?
I'm not sure whether any of the current panel knows about how it got incorporated into our standards, or whether that might be a question to say for the next panel, where it's the practitioners of who are involved in building mechanical ventilation systems who might be able to answer that.
I don't know the answer. No.
No, so I think that's a no from this particular panel.
Oh, I forgot to mention, my background, I'm a mechanical engineer for the department. So the second question was based on air change rate. Now, we've adopted certain air change rates based on health requirements and the spread as a result of COVID. We probably had the highest air change rate in Australia at the time until energy influences caused us to reduce that air change rate. We had adopted 8 air changes in our standard across all different types of facilities, and because of the influence of the energy sustainability, we were told to reduce that to 6 air changes, which is only the minimum that I would accept, because that's what's required in a hospital or health environment. So talking on that, how can we influence that sort of level of assurity of what we should do, rather than being driven by one aspect to the other, which I know that there's going to be a discussion about sustainability and
so perhaps if I rephrase the question of, we have a trade-off between what air change rate is required to minimise the spread of pathogens, and what air change rate affects the energy efficiency and the carbon emissions, in essence, of the buildings. Does anyone on the panel want to talk about that?
I just want to continue with the example of the monitoring here, because I forgot to say that the scenario that I presented is not strictly the scenario that is this one. Why? Because we had a break, and during the break we opened the windows, the concentration went down. So in principle, the exposure was the exposure of 1 hour, not 3 hours. So it's important to understand that if we want to reduce risk, imagine to be a building manager for air quality, and you have to set the condition for a safe environment. You can change the occupancy, but you can change also the time. So if you have a ventilation, you don't need to increase only the ventilation to have safe condition, but you can reduce the time. So this is important to be understood in order to manage the environment.
Anna Maria, you can.
I won't answer in technical terms, just to say, shall I project? Just to say, this is the challenge of cross-disciplinary and policy development. And I think what's really important, and one of the reasons why the Academy of Science continues to advocate for a multidisciplinary approach to indoor air quality, is that we don't end up down a road where we're only looking at meeting one policy objective, but we can consider all of the factors that are needed. Because with trade-offs, you can find a compromise. As Giorgio said, there's ways in which you can look at different factors. It would be unfortunate if we end up with every single window closed, shut, because of energy efficiency without the ability to have it open because we haven't considered a range of factors. That's an oversimplification of a policy response. It is so multidisciplinary that we do require everybody to come together. And it's something that is difficult because most policy challenges are looked at through the prism of one portfolio. And not necessarily through one discipline, scientific discipline, where we're more used to collaborating. And that's the policy challenge, I think, for us. And one of the things as an academy we've been trying to advocate for is to move out of those silos so that we can get the balance right. So our representations to the energy ministers is as strong as it is to those responsible for the building code and the health minister and others, so that they can come together.
And just to add to that, sorry, Wendy, in 10 seconds.
Counting.
In the work that I've seen from Jason and others, the aim is win-win. The aim is not to make energy efficiency worth by dealing with respiratory infections. So the innovations is win-win, or at least neutral from an energy perspective. Nothing will get up if it's if it deviates from that.
Guy, you're.
Well, I was going to say the same sort of thing. I think it is down to engineers, HVAC engineers and architects and builders to be able to accommodate a more complex, a relatively complex set of criteria, because it isn't just one dimension. It is not a one-dimensional problem. It's a multi-dimensional problem. It's influenced by the outdoor conditions. Obviously, the extent to which you want to bring outdoor air into the indoor environment depends on what the quality of the outdoor air is, what the temperature of the outdoor air is, and so it's a multi-dimensional, complex problem. I believe we have the capacity to actually solve it, but it can't be solved by just looking at one dimension. That is going to lead to bad outcomes. And we need to consider all of the elements, and we can do that.
Perhaps as someone who's sort of worked in the building ventilation space, also considering that a lot of building management systems are set up by mechanical engineers as a one-size-fits-all. We want the same. We want the temperature at 22 plus or minus 1 or 2, or it might be 24 or 25 in Darwin. And we set it so that it'll run it from 8 a.m. to 6 p.m. sort of thing, without necessarily tweaking it for different occupancy rates, or tweaking it for a higher air change rate during flu season, for example, compared to not flu season. So having some more flexibility in the way that building energy management and building HVAC management systems are set up might be part of the solution, as well as having more renewable energy to cater for the energy things, as opposed to, so you're not enhancing the greenhouse gas emissions. So a whole range of strategies to address that. if you had another question, can we hold it over to give someone else a chance at the moment? And I think there was someone.
Lydia.
Over here.
Yeah, there's one over here first, and then we'll.
Thank you so much to everyone on the panel. Really interesting discussions. I'm Emily Franklin. I'm a research scientist at CSIRO, and just reflecting on multiple of the panelists have already commented on the geographic bias in the state of the science in terms of where the indoor environments that we know about are. I was curious if people could also speak to any potential biases in the racial and socioeconomic demographics of whose indoor environments typically get included in indoor air science, how that intersects with which communities are most significantly impacted by poor indoor air quality, and sort of how those things intersect in terms of identifying that 10% of indoor spaces where potential interventions may have, the most capacity to improve community health.
Any panelists feel that they can talk on that? Right.
Well, I think that's a very interesting question and a good question. I'm doing quite a lot of work in overseas places, and I think there's very little work done in low and middle income countries on indoor air quality. I'll just give you an example of it, is in cooking stoves. So there's been a lot of interest in cooking stoves as a source of adverse exposures indoors, because people often in low and middle income countries use biomass fuel or kerosene for burning, and they're not well ventilated. The problem, and so there was a study done in Africa where they did a randomized control trial of replacing indoor cooking stoves in some houses and not in others. And this study was done, and it showed no benefit of replacing the cooking stoves. The problem is that in the villages where these cooking stoves were used, the houses typically have no walls. So there is no indoor air. There is only outdoor air. And so that if your cooking stove has been replaced and your neighbour still is burning biomass fuel, you are getting the biomass fuel. So people tend to bring with them to solving problems a construct that exists in Australia or Europe, but not the construct that exists in these settings. So we need to solve the problems of air pollution, for example, in low and middle income countries. I'll just make one other observation about the fact that that environments in low and middle income countries are very different, and dwellings are very different. I had a colleague my predecessor is I have a colleague in Nairobi who, during the height of the epidemic of COVID in Nairobi, noted that nearly all of the patients that were coming in with COVID were from the middle class, upper and middle class districts of Nairobi, and not from the slums. And my theory as to why that is the case is that the people in the middle class districts were living in enclosed buildings where there was transmission of COVID. The people in the slums were living basically outdoors, where there was very little transmission. So one has to take account of the living conditions, the environment in which things are being operated. So my general answer to your question is that we need to pay much more attention to socioeconomic gradients and to living conditions and the environment, and as it varies across the community. I haven't answered you about Australia, but perhaps others might want to answer to you about Australia.
Brendan's itching.
I can have a go at that, and I absolutely concur with those comments, Guy, about low-income country settings. Look, the 106 papers, I'd need an expert to say whether that really looked at demographics. But in terms of risk factor for infection, it tracks almost exactly in Australia. The lower your socioeconomic status, the more likely you are to get the infection. And of course, it's an indoor air quality infection. That's COVID. We're talking about the same is true for influenza. So that does tell you where to concentrate. We have that fact, and then we have some known general high risk settings: schools, homes, private homes, aged care facilities, healthcare facilities, public transport. Doesn't mean there aren't others. So putting those two things together in the investigative research that's to come, and then the policy environment, they've got to be taken into account. And it's very easy as a researcher to do studies where you can do them, necessarily where you should be doing them.
I can say about the 106 papers that are in this, there were no socio-demographic parameters reported. So of the 1,000 or so homes that have been measured, it wasn't reported where they were specifically in the socio-demographic things. However, from a policy response point of view, we certainly have to consider the demographics. So if, for example, we could phase out gas appliances in all homes, then we need to consider what does that mean for renters and for low-income households compared to middle and upper class households who, I could afford to take out my stove and put in an induction heater, induction cooktop, but lots of people can't. So the solutions certainly need to consider how to ensure that the lower socioeconomic households can equally participate in the benefits of changes such as electrification of vehicles or the phasing out of gas appliances. But there's no demographic information in any of the papers. Generally, that's not the lens by which most of these studies were done. There were, I think, two questions. Lydia had one for a start.
My question relates to the previous conversation and the example Giorgio presented. And the question is not to Giorgio or the panel, but in fact, the question is to Simon. The point is that Giorgio's assessment about the risk is based on the assumption that air delivered to this room is fresh air from outside, is not recirculated. Now, if an experiment or measurement like this was done on a plane, so based on high concentration of CO2, you cannot draw any conclusion about the risk because air is recirculated and risk overall is very low. So when we were talking about what's happening what will happen in this room, the question was, is air recirculated here or not? And no one was able to say. So therefore, without understanding this, we can't really draw any conclusion. A person who can potentially know this is Simon. What's your assessment, Simon, of the situation here?
Perhaps, Simon, you can stand up and introduce yourself a little bit on that as well.
I'm Simon Witts. I'm Director of VA Sciences. We're a building services consultancy, and I've spent a fair bit of time looking at how air moves in buildings over the 40 years I've been in the industry. Yeah, tricky. When the question was asked, what do we do about this room? Is the air quality going to be good? You don't know. As a building services engineer, I do not know unless I know the system that's behind it. I know, now I'm in here, they're swirl diffusers. So for those of you who don't know, a swirl diffuser is one of those circular things with the vanes all at a different angle. What that does is it makes the air swirl. Why do we do that? Well, because people get really annoyed if they have a draft blowing on them. So a swirl diffuser is probably the best method we've come up yet of making sure that everyone has an equal chance of getting the infection. So we have swirl diffusers.
Democratic.
So, and I don't know the system that's behind that. This is a commercial property. It's designed primarily around comfort. So you don't want people to get too hot in here. There are some minimum requirements around the amount of outside air. I'll keep the argument about supply air out for a minute, but the amount of outside air that's coming into the space, you normally design on 10 litres per second per person. So this room will have a set amount of occupancy allowed, and that's probably the outside air rate that's being delivered to this space. It's probably not the total amount of air that's being moved around, because that's recirculated through the fan coils, and the amount of air we move in a space like this is designed on how much we want to try and cool it, how much we want the comfort side of things, because people complain pretty quickly if they're too hot or too cold. So, long answer to quite a short question was, what was the air change rate? Don't know. I'm guessing it's going to be around about 1 to 1.5 air changes an hour. So when we were talking about this space, I said, probably a good idea to put some HEPA filter units in here. The question then came, how many? And I said, pick 6 air changes an hour. So I didn't check, but we've got the right number in here to give around about 6 air changes an hour of turnover in the space. Now, that's called your clean air change rate. So the amount of times that air is being scrubbed, it depends slightly on where the units are and the local actual air change rate itself, or the air exchange rate, i.e. the effectiveness. But again, I'm a building services engineer. One thing you will notice when you're in this room, because of the HEPA units, I'll stop talking for a second, just listen. If you were working in here day in, day out, that would be really annoying. So it's another factor that we have to build into how we design these things. So does that answer your question?
Basically, this shows that there is no simple answer, simple solution. If we take any action, for that action to be meaningful in terms of protecting us and not wasting energy unnecessarily, we really need to understand the scenario, the building. And without that understanding, well, we may not be going in the right direction. And this requires this multidisciplinary approach.
And each thing that you do has a whole series of other effects. You just mentioned the sound, which is not one that I had talked about, but it's clearly another consequence. So we need engineers.
Bob Sharon here from both QUT and Blue IoT. Anna Maria Brendan. We now have the evidence, though we're refining that information and research. What do we need now to get legislation happening? Because if we don't get the legislation, nothing's going to happen.
Brendan looks at me. Look, a political champion would go a long way. It's not all legislation. Some of it's regulation. Some of it is further data collection. I hate answering a question with we need more research, but in some areas we actually do need more research. So it's a range of different actions. I mentioned it earlier, but the most difficult areas to get traction on are those that are cross-portfolio and multidisciplinary. And this is that as well as cross-jurisdictional. So it's easy to say somebody else should take the lead because it's a health issue or it's a built environment issue or it's an issue for everyone. And it's one of the reasons why we, as an Academy of Science, try to elevate this as a really important piece of the puzzle in the public health framework, not just to say that it is a health issue, but that enables us to look at it through different lenses as well and go to its essential importance. We've done a lot of work, and Lydia went through the last 30 years, and in some ways, it feels like not much has been achieved, but when you look at it presented that way, you know, there has been incremental and some significant steps forward. If you draw comparisons with food safety and water quality, none of this happens overnight. So it never really feels fast enough. But a political champion would go a long way to coordinate across certainly federal government and the levers needed across state and territory governments and to enable some of the cross-portfolio work that needs to be done. I will say this. Within the Department of Health, there has been significant steps forward in terms of looking at indoor air quality as part of the environmental health section of their work. There's people in the room today who have advanced that, and I thank them for it. These are drivers of change. COVID's accelerated things, but more leadership and champions, I think, is the short answer. Would you add to that?
I would only add a little because that's I absolutely agree with that. I think the data that Anna Maria speaks about there'll be some gems in there that you can build a campaign around. So not just passively suggest that data is going to make it or even just write to the health minister, but a Grim Reaper type campaign around, which is what happened, of course, for the HIV public health messaging. We were having similar problems back in the 80s. So I don't think we're right at the perfect moment for that. Political champion, get the data, and there'll be some pieces that we can build a campaign around.
We had a question, I think, from Priya. I promise not to keep you later for lunch.
Priya from RMIT University. There was, I think one of the discussions was about the range of carbon dioxide concentration and the maximum reported 5,000 ppm. So I was just wondering, is it because that's what most of the instruments can actually measure as the maximum?
It's possible that I'm the one to perhaps answer that. Yeah, so in the particular study, I think that reported 5,000 was a Queensland study, I think University of Queensland. Yes, it could be that the equipment it could have been higher than 5,000, perhaps it was an equipment limit. But the point of the paper was that, and this perhaps leads to the question I was going to ask the panel about peak concentrations versus averages, because most of the concentration limits by WHO or by the National Construction Code, etc., are 8-hour or 24-hour concentrations, not... so in that instance, I don't know, Priya, I'd have to look back at the paper and see what the limits of the instrument were. I can talk to you later about that. But leading from that, though, is my question to the scientists then, that most of the limits are based on, or work exposure things are based on 8-hour or 24-hour averages. But what does the science tell us about what's the importance of short-term exposure or really high concentrations versus long-term exposure at low concentrations versus multiple accumulated exposures from multiple pollutants at once? There's sort of three different scenarios that are not yet included in any of our exposure limit guidelines. That's an open slather to perhaps each of you can say a minute or two on that, and then it will be lunchtime.
I would like to link your question to the previous one. What we need now, in my opinion, we need mandatory standards for how can I say, for performances evaluation. It means if we enter in this room, how can I say, I can understand if the air conditioning the ventilation is working. In Belgium was introduced a law that imposes in any public space the monitoring, and each manager has to show the concentration of CO2. This is important for two reasons. One, because people has to be educated to the importance of the indoor air quality, and the second one is if I enter in this room, I can understand the condition of the room in the same moment, and if concentration is high, the risk of transmission could be high. This is not a value that could be of interest 24 hours, but in that moment is a kind of photography of the situation.
That's similar to UK legislation that all rooms in houses that have a combustion device must have a CO monitor. That I think came in early 2024. So even just having a CO monitor in places with combustion, for example. Guy, you were wanting to say something about the concentration limits and exposure times, and how do we compare all the different?
Well, it's complicated is the short answer to that. For some pollutants, like gaseous pollutants, for example, ozone, there is a fairly good time dose response relationship that's been demonstrated in experimental studies. And I remember, like maybe 20 or 30 years ago, there was work, the limits for ozone were all 1 hour based. And then became evidence that actually a 4 hour limit would make more sense for assessing the health effects. But for things like particulates, it's a matter of how long is a piece of string. There's no clear sort of time exposure response relationship. There are effects that happen. High exposures for short periods are adverse. Less high exposures for long periods are adverse. And so you have to have a more complicated sort of formula if you really want to look at exposure response relations.
So in that sense, does it make more sense, for example, to have mandatory PM 2.5 monitors in spaces so that at least individuals can know what it is right now, and if I like some, for example, you don't want to be exposed to things. So if you walk into a room and it says that PM 2.5 is above a certain level, you can walk out or allow for individuals to take some protective action.
Well, that's a separate question, about sort of how people, what information we provide to people and how they use it. The question I was answering is, do we know what the time exposure response is? And that is a complex thing. And I guess any person wanting to take action would also need to know how long is it going to be high? And how long am I going to be in that room? And how long am I going to be exposed? Because that will influence the likelihood that they're going to have an adverse reaction.
And if they don't know what the ventilation system is, and if the building management system is set up to respond to that high level, to bring it down to a different level. Yeah, as you say, it's a complex thing. I am very mindful of the time, and there has to be monitoring somewhere along the line. So we'll get into that in a moment. So we're 1 minute from lunchtime. Brendan or Anna Marie, do you want to?
Oh, look, just from an infections point of view, it varies. Every infectious disease transmitted by the respiratory route has, a different number of viral or bacterial particles that will infect you versus not cross that line. But as a general rule, it's not an immediate exposure. It's exposure over a period of time, not hours, but exposure of a reasonable concentration over a period of time. In other words, if you change your mask indoors and it's contaminated, that in a few breaths is not as a general rule, a desperately bad thing to do. Or, eat your lunch or whatever. Like any little bit is a problem. So that's the general concept. But as Guy says, it depends so much for infections, just like it does for other things. But in the main sort of the 10 minutes to an hour in a contaminated area is the sort of range you'd be worried about.
Okay, Anne-Marie?
Final comment, measure it and we can manage it.
Okay. Final word from Lydia. Remember, it's 12:30.
I was just going to add that we have answers to these questions in relation to PM 2.5, PM 10. There are exposure response curves based on epidemiological studies, but the evidence is only for annual and 24 hours. No studies so far have been done for shorter average in time. So that's why in our science paper we propose for 1 hour, but take 24 hours. However, if we were to do what normally it goes, it would be higher. So it's very conservative, and it's in detail explained in our science paper. So there are answers to this.
Okay. Thank you very much. I want to thank our panellists. So Anna Marie, Brendan, Giorgio and Guy. And after lunch, we have we have an hour for lunch, and after lunch we have another panel session that's going to focus on the in practice. What do we need to go further? So we have a speaker from the ACTU, so a union perspective, a facilities management perspective, Simon as a building engineer, service engineer, and Jeff as an architect. So we'll look at the practice of indoor air quality in the next session. Have a good lunch and we'll see you in an hour's time. Thank you.